Welcome to the Show Me Casey Schools podcast. We are here today with a few guests. Today we're going to be talking about mental health. And so I'll let each of you go ahead and introduce yourself and let us know what organization you're with.
My name is Angela Guzman. I am the Behavioral Health Community Education Coordinator from Children's Mercy, and I'm happy to be here.
My name is Kristin Feeback, and I am the President and CEO of CommCare. And we have many lines of business, but our main line of business is we are a 988 call center for Missouri.
I'm Heather Mason. I am a program manager with ReDiscover over our mobile crisis response services.
Awesome. Thank you all so much for being here. So I do want to give a little context because typically the Show Me Casey Schools podcast talks about how to search for schools, navigating the education journey, things like that for parents and students. But we really want to keep our pulse on what families, parents, and guardians want to hear about. And we recently did a survey, and one of the topics that came up for just about every respondent was they wanted to hear about mental health. And I talked to Angela, and we had coffee, and I was like, I don't know how we're going to do this. There's so many ways we can talk about mental health. But I thought we would at least start with just kind of level setting, talking about some of the resources that are available to families and teens and things like that in the city. So in order to go ahead and get started, Angela, I'll start with you. Could you share a little bit about some of the signals or signs that families may notice in their child or their teenager that may signal that it's time to reach out for some mental health services?
Absolutely. Thank you. That's a really good question. And can I say, I am so stoked to be here, and I'm so stoked to be here with all three of you. And these, my friends, are such amazing behavioral health advocates and providers, and they do such good work. So I'm super stoked to be here.
We love to be around her because she talks very nicely about us. So
it's all true. And I'm truth telling. It's so nice. So to your question, in when to access care, when to start seeking care, what are some of the things that families, some warning signs, symptoms, and then how you get to care? I instantly think we need to talk about crisis, because that is probably the biggest fire we want to put out. So if a parent has a kiddo that is expressing suicidal ideation, and if they're actively unsafe, and an example I think of is a kid says, I'm going to kill myself, goes in the bathroom and locks the door. Oh my gosh, that is 911 immediately. And if a parent finds themselves needing to seek immediate care for their kid, head to the nearest ED. If your kid is unsafe, get to that closest ED.
And you're saying emergency department.
Emergency department, yes. Thank you. If I start speaking in acronyms, which happens in behavioral health, you just let me know. Yeah, get to that ED, because once at the ED, that kiddo will be assessed by, in our ED at least, a master's level clinician. And from that assessment, they will develop a plan and figure out next steps for the family. They'll also talk to the parents about means restriction or means storage, which means, how many times can I say means in a sentence? We want to create time and space between that kid and those items that kids typically use to, and actually adults too, use to end their lives. So we really encourage parents to lock up or get guns out of the house if possible. But if not possible, we want to lock up ammo separate. We want to lock up our sharps, so that scissors, knives, anything someone can use to cut themselves. We want to lock up medication because we see a lot of ingestions and overdoses in our ED, emergency department. And one of the things that we often hear from families or from parents or from kids is when asked how many medications, how many pills did you take? A handful. So we want to make sure that kids don't have access to large quantities of medication. The other thing that we want to lock up or restrict is ligatures. So anything that a kid can use to wrap around their neck, we want to remove those things too. So those are the things that kids typically and adults typically use to end their lives.
Okay. Yeah. So, and I know we'll talk a little bit more about urgent care and accessing services through the emergency department. I think some of the feedback that I often get with just interacting with friends of adolescents, even small children, is they don't quite know when to turn the corner on, like, is this a developmentally normal behavior, or is this something that I should start seeking out some resources? Can you talk a little bit about that? Some of the things that parents may see that may indicate we may not need to access emergency services, but it's time to start making phone calls to access therapists or other mental health services.
Absolutely. So I think before I dig into that, one of the things that I want to start with is if you're seeking care for your kiddo and you're not necessarily seeking crisis level care, but you know your kid could benefit from some therapy or other behavioral health services, do it sooner rather than later. And for a couple of reasons. One is because we don't want those behavioral health concerns to worsen and then develop into a crisis. And the second thing is, in our behavioral health landscape right now, wait lists are a very common thing. So if you're thinking about it, go ahead and get it done. Get them connected to a therapist or other behavioral health provider. So some of the things that I think about are parents know their kiddos best, but you're right. I think especially in the teenage years, as a parent of teens also, it can be really challenging to go, is this my kid being a teen or is this a behavioral health concern? So I think when you notice a change or a difference in your kid, if they're not finding like that joy or happiness or pleasure in things that they formerly did, or if you see them withdraw, if they're doing more poorly in school, if school personnel says, hey, I think you might want to get your kid in to see somebody, heed their advice, heed their suggestion, get them in to see somebody. For, I think, more significant, like when it becomes more, I don't want to say crucial, more on the suicide end of things, like suicidal ideation end of things, when kids start saying things like, it would be better if I wasn't here. If I just didn't wake up tomorrow, that would be better. So they're saying things like that make you feel like they feel like they're a burden. Those are definitely indications.
Okay.
Social media. I mean, I have had parents talk to me about things that either their kids' friends or their kids have posted on social media that was concerning. So that can like be an indication that a kiddo needs some behavioral health support or help.
Okay. That sounds good. That's helpful. Yeah. It is really tough with those teenagers, man. It's like,
I have two.
I don't know how you do it with the two. I just have one. And that's more than enough for my household.
Well, I think the evolution of Snapchat and all these things, I can't even tell you the amount of times that we've had 911 responses where we'd have to go out there because somebody posted something on Snapchat that was concerning and it got screenshotted and got, put out there. So the 911 is responding. And that's really scary too for someone. So I think those are platforms that sometimes adolescents feel are secure and only certain people are going to see them. So I think even kids being educated is really helpful because then they can call in when their friend is needing help. And that's what we see a lot, our friends becoming concerned for their peer and calling or letting their parent know and getting access that way.
Yeah, that's good. Speaking of that, Kristin, can you talk a little bit about, and we'll go into more detail in our second segment, but can you talk about some of those instances that may be a good time for a family, individuals seeking, like when is it time to call 988?
Sure. That's a great question. So really one thing that I want to stress with 988 is it is a suicide crisis hotline number. And when we talk about the crisis piece within that, the reason why we have that number is anybody defines what a crisis is. So a lot of times people may call for some of the things that Angela and Heather were saying because they're curious and just need to know what the next steps are and know what resources are out there. 988 is not just for a person that is going through a crisis or having suicidal ideation themselves, but we do get a lot of calls from family, from friends' parents, just having some concerns maybe about a specific behavior, a certain statement that somebody's making, and really just need some clarity and some resources. So the thing with 988 is you can call anytime. It can be anybody. And what you'll get is a crisis counselor that's trained to speak to and really, I consider it a warm line. So it's a line that you call to, really, like I said, a crisis is anything that you deem as a crisis. So
that's really helpful. I know I've talked to some parents who've had situations where it's like, my kid's friend is kind of doing some things that's concerning to me, but I don't quite feel comfortable taking it to the parent. I don't really know what to do.
Right.
So that's helpful to know that 988 could also be utilized for that, just to get some more resources around next steps for things. Or if a friend wants to call in regarding a peer, getting access to help and things like that.
Well, and the other thing I do also want to say is it's not just calling. It can also be through text and chatting.
Oh, yeah.
So some people just are kind of more would prefer texting or chatting than to actually call. And so as the number came out in July of 2022, our numbers of call volume, texting, chatting is all increasing every month. So more as people know about it and utilize it as a resource.
Awesome.
Can I just say how much we love 988 as a safety net? And it is like in behavioral health to be able to tell families, if you have any question, if you have any concern, call this number is so helpful. And then I think that the other thing, and maybe it's changed, I want to make sure I'm not fibbing here, but I know one of the things when I talk to folks about 988 is their concern about like anonymity.
Oh, yeah. And I can speak to that too. So, and I know in the second half, we're going to get more in details, but yes, it is 100% confidential. We will ask for some demographic information, but it's up to the person that's calling if they want to give that information out or not.
Okay.
And so I think that's the thing. That's what makes it really a good resource, is because, sometimes people are apprehensive about reaching out because they just, at comfort level, they may want their identity hidden.
Concerns about what could happen.
Yes.
I think sometimes institutions just kind of get all lumped together. So it's like,
that's right.
Is Children's Division going to get called if I do
Police
this?
gonna show up.
Somebody going to come in and take my kids because I expressed the concern regarding them and tried to get help. So, and that kind of leads me to my next point, Heather. I was going to ask you to kind of talk a little bit about some of the stigmas and myths that you all kind of see in this space. And just speaking to, really, I guess, debunking some of those. But what would you say to some folks that are carrying some of these stigmas and myths? And can you speak to some of those?
Absolutely. I'll start with the main one that I feel like we get, especially with when we're trying to create a safety plan with families. We always look at least restrictive level of care and how can we keep kids in the home so that they can continue with their routine. We know that's a huge part of their daily lives, is being able to attend school, go to their activities. And so we don't want to cause disruption there. But with that, we need to have a safe plan. And I know Angela talked on restricting means and things like that, but a big piece is asking, are you having those suicidal thoughts? Are you having thoughts to kill yourself? And being very specific. And parents get a little weary because they think,
if I ask.
Yes. If I ask, I'm putting that in their head.
Yeah.
And then they're going to do it. And there's this shame and guilt and this fear.
Yeah.
And it is shown that is completely false. It's a myth. If somebody's having suicidal thoughts, they're already having suicidal thoughts. By you asking, you're opening up a safe space to have that conversation so they don't feel that shame and that judgment. And they can have that open conversation of, hey, I've been struggling with these intrusive thoughts, but I'm really glad you asked. I do want to be safe. Let's talk about it. And having those routine check-ins, it's not going to cause them to start thinking about it. They're already thinking about it is the thing. We're just not asking.
Yeah.
And so I think that's one of the main ones we get. And I really like to put that out there, especially when we talk about the suicide. 988 is a suicide lifeline, but it's also crisis. But I would say that's one of our biggest ones surrounding suicidality. I think another, just in general, kids, adults, if I, talking about the access to care, if I get help, school, all these things are going to happen with school, my job, I'm not going to be able to go back to work. And really, I just want to put out there, a lot of what we find is, there's programs within schools to help if kids need to get out of school for a little bit. There are intensive programs after school to help with this. So there are options that don't have to disrupt someone's lives completely, that are intensive. But also being mindful of, we've come so far in mental health that there's so much grace around getting services. And that's really what people want. They want people to be healthy, and that includes their mental health. So being mindful of, we can always find a way typically to support treatment instead of letting it being a barrier of, but school won't support this, work won't support this, and having those conversations with your mental health provider so that they can provide the documentation, they can help assist with that process.
I think to your point too, like I've had kids say, I don't want to tell you because if I tell you, then you're going to send me to the psych hospital. And that is not like, I mean, that's exactly what Heather's talking about. Like that least restrictive environment. We want to give kids like the right amount of care, preferably in the community. If they do need more intensive care, it's there. But there's pretty stringent criteria that also has to be met for a psych hospitalization. And it's more than one person's decision. Typically, it's usually several professionals involved in that decision. And so like, I think sometimes kids are like, my mom and dad, they're going to send me to the psych hospital. That's not how that works.
No, I'm so glad you said that, because that is a huge fear. And we are so focused on making sure everyone has the right training to provide the least restrictive level of care. We recognize that inpatient isn't always the best option, because we want to be able to provide wraparound services so that people can maintain their regular routines. So with kids, even just because they may not want to say I'm suicidal or I'm having these thoughts, because to them that means, oh gosh, I'm going to go to the hospital and I'm going to miss my friend's plans on Friday.
Yeah.
So to us, we're like, well, you're future focused. You're worried about missing your, movie night. And so it's just really getting the right assessment and the right wraparound services. And there are times when that's appropriate to escalate care to that point. But we really want to focus on that being the last option.
Right. Can I say something just really quickly? Because this has always been like something that has, I get bamboozled me just a little bit. When I've met with families and I've done suicide assessments, and during the assessment, you find out that there's a therapist involved, and you ask, so have you communicated with your therapist? Have you shared this with your therapist, that your kiddo's having like thoughts of suicide, thoughts of ending their life? Or if kiddo, have you spoken to your therapist about this? And so many times the answer has been no. And I am like, that's what the therapist is there for. Like, please talk to please talk to your therapist if you're having thoughts of ending your life. Like that's, really, really important.
Yeah, because they're there to prevent it needing to get escalated. If they can process and work through those lower acuity thoughts, then it can hopefully prevent from it getting escalated. So.
Okay. Well, we are going to break there. When we come back, we're going to dive a little bit more deeper into what services are available, some community resources, how to access therapists or mental health professionals at some of these different resources. And we'll also be able to dig a little bit more into 988. We'll be right back. All right, we are back with the Show Me Casey Schools podcast, and we are talking about mental health and mental health services in the Kansas City, Missouri area. So what I wanted to do was kind of start by talking about community behavioral health centers. Heather, could you explain what those are and how families can access those centers and what resources they include?
Absolutely. So I'm going to try to do it in a way that is not confusing, because when we talk about catchments, it is confusing. Yeah. It is. And so I will put a plug. One way people can look at their location and areas also by going on the DMH website, and they can see their catchment and kind of where they fall. You can also use 988. They have a map and can help you as well. But
we'll link both of those in the show notes.
Oh, perfect. But overall, so as a community mental health center, our mission is truly to help. We serve people with mental health or substance use disorders, and our goal is to help them achieve healthier and more productive lives. We want to break down barriers. So we want to serve anyone and everyone, regardless of insurance or ability to pay. So that's one big thing that sets us aside, is we are typically really able to support our population that may be underserved or uninsured or underinsured. So we have different availability and things to help with that. How we look at catchments is essentially they look at populations, they look at kind of the radius around something beyond what, I'm capable of in terms of looking at geographically. But what they do is they want to look at how the population, how many they're serving within that area, and how are they going to ensure best access to that. So ultimately, you'll look at catchment in like downtown KC-Mo. It's a smaller area, but because the population is bigger, they can ensure better access. As you start to go out to maybe like Eastern Jack, you'll notice it's a bigger radius, but they may have a few different intake locations. So ultimately, the state does break this down in that way. And then, like I said, it's on the website as well. But ultimately, it's just based off of your address. Okay. And with that being said, though, we're going to talk about a lot of crisis programs. And just because you have a certain catchment doesn't mean you're glued to that catchment. Okay. Like I said, we want to break down barriers. We want to give people choice. There's a lot of services that catchment doesn't matter. So I don't want people to feel, really restricted in that. So if they get access somewhere, we're going to help them to get where they need to go. We're going to meet the immediate need, and then we're going to figure out where do we go next. So I just want to put the plug of don't get too concerned that you're not going to the right place. That facility will help support you, and they're going to get you what you need, and then they'll hand off to that next place.
And just to recap for our listeners, the Community Behavioral Health Center, there's several in the Kansas City area, and each one is attached to a catchment area, correct?
Yes, correct.
But again, you're not necessarily tied to that area. Could you list what those centers may be? Just so I think sometimes families hear the names of things, but don't know that, that's a community behavioral mental health center.
Absolutely. Yeah. So if we're looking north of the river, it used to be known as Tri-County Mental Health, but it's now Beacon. And then as you come downtown, we have Swope and University Health. Okay. And then as you start to go a little more east and south, you're going to hit ReDiscover, and that covers out to all the way to like Lone Jack, Lottawanna, Lee Summit, Raytown, Grandview. Okay. And then we have Comprehensive and Burrell, which are like our Independence, Blue Springs area.
Okay. And then again, I'm going to make sure that we link the site so that folks can check their catchment areas to see what center they may be. Yeah.
And ultimately, we all collaborate within these mental health centers. We have regular meetings and care coordination. So we're going to work together to make sure that person's needs are getting met as well.
So when we refer to mental health centers from the hospital, there's a specific role at the mental health center, and they're called a youth behavioral health liaison, this YIBL position, which I love, because if we accidentally send a referral to the wrong mental health center, say we send it to Swope and it should have gone to University Health, those YIBLs communicate and that referral gets to the right YIBL.
Okay, great.
YIBL, youth behavioral health liaison. I don't know if that's
okay.
But each center has one, and they are working with schools, law enforcement, things like that to help divert and connect families.
Okay, awesome. Yeah, because I know that back in the day, they used to cause a lot of confusion because folks didn't know where to go and were concerned about how that could potentially stall services. So it's great to hear that we have some roles in place everywhere that's kind of helping catch when things may go to the wrong place, make sure folks are getting to where they need to go.
Should we talk about open access for just a second? Because I think that's important, but there are also like some important pieces to know about open access.
Yeah, open access at mental health centers are all different. Most of the time we have walk-in centers. So I can speak probably for downtown. I know ReDiscover, there are some opportunities for appointments for open access, but usually it's walk-in. I would definitely check the links for hours because they're all different, I'm sure. But that is how you can access a variety of services. So if you're looking for a therapist, a case manager, a med provider, more long-term, we have peer support specialists. We have, partial hospitalization, all these different types of services. It's really a one-stop shop to go in there, go through the process. Takes usually about an hour and a half. You're going to get asked a lot of questions so they can better kind kind of figure out what your needs are. And then they're going to refer you hopefully internally to that best service. And so usually that's something you're just bringing your general information and you'll show up and hopefully you'll be seen by a master level clinician as well.
Okay.
And so, and then they'll, like I said, their job is to connect, look at catchment, all those things to ensure they're providing the best referral. And from there may be a wait. Everything, it just depends across the area and things change day to day, it seems like, but there may be a wait. I feel like most of the time the waits are maybe 6 weeks. It could be longer, but it's nothing typically where months and months and you really have to worry about that.
Okay.
So, and usually we have such a broad range of crisis programming that they'll set up some services in the interim to bridge you over until you get connected to a more long-term treatment.
Okay. Yeah. Cause I know that that's some of the concern as well. Like how long am I going to be waiting to get access to some of these services? Angela, I know previously when we met, you and I talked a little bit about how, pediatricians and physicians are doing work to try to help connect and bridge the gap for behavioral and mental health services. Can you talk a little bit more about that?
I am so happy that you're asking me about that because I actually came from a meeting today with a couple of folks that
she really teed you up for this one.
I know. Thank you. I'm just going to spike it now. So at Children's Mercy, we have our primary care clinics are on Broadway, that big building on Broadway. And we've integrated behavioral health clinicians into our primary care clinics over there because we know folks are often told or parents read, like if you're worried about your kid's behavioral health, if you've got a concern, talk to your pediatrician about it. But sometimes there's a gap from pediatrician to behavioral health providers. So in order to close that gap and open up like equitable access to care, we have behavioral health clinicians that can be there in the moment. So if a physician is made aware that there's a behavioral health concern, they can call a behavioral health clinician in to provide support right then and there, which is lovely. And then we've got some integrated in the community with some of our affiliated practices too. And then throughout the community, I think there are some pediatricians that have put some social workers in as part of their staff or other LPCs that are just part of who kids have an option of seeing when they come in. So not everybody, let me just say that, not everybody, but some people in at Children's Mercy were doing that.
Well, it's good to know that that's growing. If it's already starting to happen, then that means that maybe some folks who don't have it already set up in their offices or working towards that. So that's great. I know in the first half, we kind of touched on accessing emergency rooms being a touch point for some of the crisis intervention. Can you all talk a little bit more about other urgent care options that families may have? I'm looking at Angela and Heather to kick it off.
This is an exciting question. Yeah. To start.
1, 2, 3, go.
Urgent care models are starting to pop up across the state. They're getting funded statewide, we've noticed, but mostly it's been the adult clinics, 18 and up. What we just opened regionally, it's located in Raytown. This is not something that we talked about catchments. It doesn't matter what catchment you're in. Don't be stressed out. So anyone can go to this. It is called our Youth Behavioral Health Urgent Care. It's located at 7001 Blue Ridge Boulevard in Raytown. It is open 7 days a week, 9 a.m. to 9 p.m. The last walk-in is typically around 7:30. And like I said, this is 7 days a week, holidays, all the things. So what's really unique and exciting about this clinic is it has the medical model for an urgent care. So the goal is instead of having to go through the ER, say I have a kiddo who's been really depressed. I've noticed some changes. I'm really thinking they need to be on some medications, but gosh, I called an outpatient psychiatrist and it's a 4-month wait. And, I know the ER can't prescribe typically medications like that. And I don't want to send my kid inpatient. So what do? This is a great opportunity to bring your kiddo to our youth urgent care, and you're going to be seen. You're going to walk in. You're going to go through a brief. You're going to fill out some paperwork and things like that. Then you're going to meet with a nurse who's going to do some basic vitals, and then after that, you'll typically meet with a qualified mental health professional who will do a crisis assessment. And then you're going to see either our psychiatrist or a nurse practitioner, and they're going to be able to prescribe medications that same day is the goal. We have a pharmacy on site, and you can leave with 30 days worth of medications right then and there. And then you see a case manager who yes, you came to the ReDiscover clinic, but maybe you live in the Northland. Okay, let's provide that information to Beacon then. That case manager will provide those next step for referrals. Right. We can definitely bridge those services in the meantime, but the goal is then to partner, collaborate, and really pass them off. Handoff. Yeah, so it is an opportunity though to get an immediate mental health assessment and to get access to medications same day. So if you're needing any of those linkages right away, it's 7 days a week you walk in. So it's a great service. Even there's options like Medicaid specialists who can fill out that paperwork and hopefully get that approved and sent same day. So there are just, there are so many opportunities to get connected there without having to escalate that care. We keep talking about least restrictive. Yeah. And as a family member, if you're not really sure, like, gosh, I don't know if this is urgent care, or if this is ER, worst case scenario, you show up at the urgent care, you're evaluated, and they feel like, you know what, this needs to be escalated. We feel like they're too unsafe at this point and need a higher level of care, and they'll help facilitate to the ER.
Okay.
Yeah. So it's a great resource. It's been open since June, so it's still in its infancy. Yeah. But it's been great so far.
Can families who are not insured access the urgent care?
Absolutely. It doesn't, regardless of cost, insurance. Yes, please do.
Awesome. You have anything to add for the urgent care?
I just think that this is such a great alternative to the emergency room. I mean, sometimes folks do need to come to the emergency room. Absolutely. That's why we're there. But like Heather was saying, if you're like, I don't know. I mean, I think parents struggle with that. Oftentimes, like your kid hurt their ankle. It's 8:00 on Tuesday. Yeah.
Do I
Is
go
it
to
urgent care or emergency?
ER?
Yeah. And it's similar to, like with behavioral health too, like in not knowing. So I think this is just such a lovely alternative. And if we can circle back to our ER for 1 second too, I think one of the things that I like to do in my position is hopefully clear up communication and make things easier for parents by providing information. And I think when parents sometimes come to the ED, their kids in behavioral health crisis, that is such, I mean, everybody is in such an escalated state. Like thinking clearly is not really going to happen at that point. And totally, I get it. We all get it. But I think knowing what happens next down there can be really helpful for parents. So like I mentioned earlier, we assess, we take a look, and then following that assessment and developing the plan. Thank you for mentioning that safety plan too, Heather. I think I was a little nervous and I missed a couple of things. So I'm going to circle back to a couple of things too. But that plan may be that we discharge home with the safety plan and with coaching parents around means restriction and means education. And sometimes I think that's frustrating for parents. And it's what it is really is this is the level of care is what we're looking at. Like what is like the most appropriate next step. So if we say, here's the safety plan, this is what you can do to remain safe in your home and like get connected to these services. We've developed this plan with you. We're not just like, we don't have anything, we're not doing anything for you. Sorry. Right. See you later. That's not what that is intended, but I think sometimes parents, when they leave with the safety plan and they're discharged home, feel that way. And really it breaks my heart because I'm like, no, this is really.
Is that because they're expecting the medication prescription and to talk to a mental health professional right then and there? Do you think that that's where some of that frustration comes from?
Maybe so. Okay. And that is one of the things from the ED. Like we aren't like psychiatry providers in the ED. We're there to like help you with your crisis and help you like stabilize down there, but not see a psychiatrist and start medications at that moment where the behavioral health urgent care, I think, has a little more leeway with being able to do that and then have, more coordinated care.
Absolutely. I think what we're seeing too is, like she mentioned, where the urgent cares are being used as part of the safety plan. So what we want to do is when appropriate, divert people from the ER. We know it's a lot of time and it's a lot of money.
Yeah.
And then when people are frustrated with, here's a safety plan, go to this place, it is going to cause frustrations, and maybe people won't use the system again because they're frustrated with it.
Right.
So we want to eliminate those barriers as well. Our goal within the clinic, I know they're really working hard to have it be in and out in 2 hours. So you walk in, you fill out this paperwork, you see all these people, and you're on your way, hopefully in 2 hours. Things happen, there's waits. The goal is though 2 hours. So, which is such a different mentality than maybe if you're going to an ER, it depends how busy it is.
Yeah.
You may be sitting in a waiting room for several hours before you're back in there, because they have a lot of medical crises going on, and we are specific to behavioral health. So as these clinics pop up, we are seeing higher diversion rates and getting people connected with the care they need. So ultimately, we're looking at the most appropriate care, at the right time, really getting people connected immediately.
Yeah, that's awesome. We're also going to include that information about the urgent care clinic in the show notes.
Yeah.
Kristin, I have seen billboards about 988. I have the magnets, the pens. Angela hooked me up with a bunch of stuff. I'm seeing a lot more promotion around it. Can you talk a little bit more about it? What it is, what it isn't, and services and resources that are provided through that.
Sure. So just to give you some context is, there's a crisis line. It's a 1-800 number, and that line is still working. Okay. So it's always been functioning. The National Suicide Hotline number, that's still functioning. But the whole purpose of 988 was to develop a 3-digit number that would be, upon having a crisis, would be easy to access and could be remembered.
Yeah.
Okay. So basically it started in, as I said earlier, July of 2022. And it was a soft rollout initially. There wasn't a lot of advertisement around it. Mental health professionals were getting educated about this number coming and what it did and what it was about. But mainly it was, we didn't know exactly what that call volume would look like. And we wanted to be prepared and make sure to get those calls answered quickly and timely, and get texting services set up correctly and the chats and different things. So there was a soft rollout. And within the last, probably about the last 18 months, we've just really focused on advertising, getting the word out, educating mental health professionals about 988, hospitals, clinics. And so what it is what we talked about earlier was it is a crisis hotline. And that is the person that's calling is going to define what the crisis is. So there's never a person that calls and is turned away. Okay. And every phone call is answered.
Awesome.
Every text is answered. Every chat is answered. And that within itself, I hope, gives people hope. Okay. But, so when somebody calls it, our main focus is safety. So we ask, aside from connecting and trying to build rapport with the call taker, is we are going to start asking 2 prompting questions. And depending on how the the caller responds to those questions, is if we ask further questions and, just to basically get an idea of what the crisis is and what the situation in which they're calling for is about. If it's found that they are in immediate danger, or the person that's calling on behalf of somebody else is immediate danger, then there are times, and it's usually 1% of the time. Okay. So 98% of the calls we get, our warm line, we talk with the caller and, really try to figure out what the situation is. But 1% of the time it is imminent danger where, a person, whether they're calling or somebody's calling on behalf of them, is an immediate harm.
Okay.
And so in that situation, we do have to utilize 911. And then the other 1% of the time, which I know that question's coming up here, and I'll do a lot of talking with Heather, we can dispatch a mobile crisis team to the location. So basically what we're trying to do is that 988 is for resources. It's for a line that anybody can call at any time. We've gotten calls from people losing their job to, hey, I had one of my friends, one of my daughter's friends came over here and was saying a couple things to me. I'm really concerned about her mental health and I just didn't know what to say. I didn't know what resources were out there. I don't know what my next step should be. Should I talk to her guardian or whoever she's living with? Or, I just don't know what to do. Can somebody just kind of help me with that? And that's what that crisis counselor is trained for and on the phone, ready to answer and respond. Or if you text or chat, that's an available resource as well. The other thing I like about 988 too is there's 3 options when you call it. So there's a recording. It's very brief, but if you're a veteran, if you hit option 1, you will immediately, a crisis counselor that is well trained in dealing with veterans situations, or sometimes it can be a vet themselves that's answering the phone.
Oh, wow.
That's trained in crisis. So you'd hit option 1. Option 2 is if you're Spanish speaking, and it will go ahead and in Spanish say hit option 2. And option 3 is if you're in the LGBTQ community, you will be transferred to a gender affirming crisis counselor that has experience. So there are those options too, because, sometimes that can be another is equity. People are kind of concerned, well, I don't know if whoever's going to answer the phone understands my situation or, what kind of services I have accessible to me.
Yeah.
So there are options. If you don't hit any of those 3 options, you directly go to a crisis counselor.
Okay.
So, and just to let everybody know, I think initially, and I don't know crisis hotline numbers if there was a long wait, but we do have an average speed to answer rate. And right now for the state of Missouri, I believe it was 14 or 15 seconds last month.
Okay.
Compared to what it was prior or when it was just the National Suicide Hotline number. So we are getting the phones answered quickly.
I don't have to call and be sitting on hold.
Oh, no. Okay. And the other thing too is there's 7 call centers in Missouri. Okay. And so what we also have is a national backup center. So let's say we have 6, 7 people on a shift answering the phones and everybody's busy handling callers. Then that goes to a national backup center. So a call will always be answered. And I really like to stress that with people. It doesn't matter what time it is.
Okay. That's awesome. So, I know it doesn't happen often, but can you all talk a little bit about what the mobile crisis process looks like? So if it's deemed that that's necessary, what happens?
I'm going to go ahead and start out by talking about it because and then I'm going to turn it over to Heather. And the reason why I'm going to talk about it is because when we get a 988 call and the call taker is on the phone getting the information, depending on what the crisis or that situation is, it may be handled better in person. And so what our call taker does is they will offer a mobile dispatch unit to come in person, or the person on the phone may say, hey, I heard about this mobile crisis team. I really would like to have one. And at that point, then we initiate a phone call and dispatch a mobile crisis team. And then I'm going to turn it over to you, Heather. And what happens after that?
Oh, this is great.
Once you get the call, what happens?
Once you get the call, what do you do?
Strap my boots on.
Yes.
No. So this is great. And in speaking about this, I want people to be aware of this is a statewide initiative. We are required to have mobile crisis responders available 24/7. And we all collaborate monthly to really try to meet the need regionally in a consistent way. So we have meetings to make sure that if somebody calls 988 and asks for a mobile response and CommCare dispatches us, that you're going to get the same response north of the river that you would downtown versus out east. So, and speaking of that, how it works is we get dispatched and we have people always ready, like I said, always on call or either on site, ready to dispatch. We have to respond within an hour is our timeline. So we have typically teams of 2, and this consists of either a master level clinician or a bachelor level with behavioral health related experience in training. And then our other component could be what we call like our tier 3 or tier 4. And this could be a peer support specialist. So somebody with lived experience. There's a variety of people. So we've been really trying to enhance our services and be inclusive of peer support specialists so that we can have people who can use their story to instill hope and inspire. Yeah. So it's been a really beautiful collaboration, and we're lucky to have 2 specifically on one of the teams that I work with. But speaking in our adolescence, we get a lot of families calling because they're frustrated. Maybe there's been a behavioral incident and they're really struggling. And so that's okay. If that's a crisis to that family, we're going to go out there and dispatch, and we're going to bring our team of 2, and we're going to try to see what's going on, see if we can get a good assessment. Our goal is to assess somebody the same way they would get assessed in an ER or an urgent care, so that we can provide the appropriate level of care recommendation. Okay. So we want to do least restrictive. So if we think this person isn't really needing to escalate to inpatient treatment, we're going to do our best to keep them out of the hospital with a safety plan and a variety of resources. Some example we will typically try to go out without law enforcement, but if there's a safety component, we may request law enforcement. So there are co-responders popping up across the state as well. So if 911 is ever called, families can also ask for a co-responder, and that is a behavioral health staff that is connected with the police department and is call responsive with that police department. Okay. So that is a resource that isn't everywhere, but it is in several places in our area. But if there isn't something like that connected, example, we had an adolescent who had been having some property destruction and had access to things and was actively, swinging a bat, things like that. So we're not trained to necessarily, handle that without making sure it's safe. So that we said, hey, we're going to come out there. Is that okay if we bring an officer to ensure safety? No problem. Able to go out, de-escalate. Officers could leave. And then the clinicians were able to make a good safety plan with the family. Okay. We've had instances where we had one, recently where the kiddo was suicidal, isolating. Mom couldn't get him out of the room. So we were able to go and sit with him in his room. The team was able to sit there, assess, and then refer to that next level of care and really just meet the kiddo where he was at and get a good assessment and escalate to the appropriate level of care. So those are just a few examples. We get a ton of adolescents, but the goal is really to work with the family, assess as they would be assessed, and provide the right intervention, the right time in the community. So we're bringing kind of that service from the hospital to the person. Mm-hmm. Yeah, to the person. And crisis services are typically there's no fee attached. And what's great about this connection is there's a vast, amount of all of these crisis programming. So say we talked a lot about suicidality. Well, we have suicide prevention programs that then we can connect to. So it's a great connection point as well.
To different resources. Mm-hmm. Awesome. Well, I have a feeling that we're going to be back on the couch talking about some more mental health resources, because I just kind of want to keep diving deeper and deeper into certain things. But I think this is a good pause point. I won't say stopping point, because I think we need to continue this conversation. But we will be sure to make sure that all of the resources that we talked about today are linked in our show notes so that listeners have access to that. 988, the DMH website to check catchment areas and locate, mental health centers that they need. Links to Children's Mercy resources, things like that. But I'm certain that we're going to get some feedback from some of our listeners and viewers that's going to prompt some more conversations around mental health services and the work you all are doing. I want to thank you all for joining me today. Thank you for the work that you're doing and the commitment that you have to our residents in Kansas City. I appreciate it so much. For our listeners, don't forget to subscribe, do all the things, share, and we'll be back with Show Me Casey Schools podcast. Show Me Casey Schools is committed to providing you with vital information that supports you while you support your child on their educational journey. Connect with us on social media at SMKCS and on YouTube at Show Me Casey Schools and on all your favorite podcast platforms.